Take your seats. We're going to get started with a question and answer now. We're going to open it up for questions. Please tell me your first name and who you want the question directed to. Any questions? First one? Oh, Marsha.
That would be my first name. That was the test. To all of you, this might be oversimplifying things, but I am reminded of the story of the people who were sitting on the bank of a river, and there were people floating down the river in the process of drowning, and they were pulling them out one by one. I mean, everybody's probably heard this story. And eventually some smart person said, let's go to the head of the river and see what's happening in the first place and who's throwing them in. This may be oversimplifying, and I don't, I'm not an expert, certainly, in the field of substance abuse, but I'm sorry, it seems to me that the physicians are the ones who are throwing people in the river, and I wonder why they're giving 90-day prescriptions for Percocet for somebody who may have a sprained toe that may hurt. You had mentioned, I think it was Stephanie, you had mentioned about getting a prescription for one of your children, that was 50, 60, and without an explanation. My question would be, why are they giving that many in the first place? Never mind the explanation.
This can be answered by all of them. We'll give it to Stephanie if you want to add. Someone wants to add.
I think for my daughter, just to cut the doctor some slack, she was exhausted. We're in Fall River. She wanted to make sure we were attended to and we were all set and didn't need to make another trip or have to call her for a refill. That's all the best that I can say. I know now it's changing. Legislation has changes, so they won't have those prescriptions. They won't be allowed to do that. But again, their education, these doctors are now going to get educated. Laura's working to help educate them, but right from medical school, and she has a follow-up. She has a 2-year follow-up, and you know what? I'm going to ask her that, and I'm going to do my job and say, why did you do this? The best that I can say is because she's in Boston and we're in Florida, and she didn't want us to have to worry, and we'll make sure we had enough.
Thank you, Stephanie. So I had the same question when I first got into this field. My background is actually in strategic communications and sociology. My lived experience was kind of what I was going on when I applied for the position within Southcoast. I was already at Southcoast working in public relations. My sister started her addiction with diagnosis of fibromyalgia at age 20 and was given Percocet to treat the pain. And what I've realized working, with the doctors, and now we do have a very active group of doctors that have recently come together in New Bedford. They're called the Physicians to Prevent Opioid Abuse. And there's another group, the Nurses to Prevent Opioid Abuse. And these doctors come from all different backgrounds, and they want to be part of the solution here, part of the front lines fighting. Some of the doctors feel duped a little bit because back in the 90s when, and even I guess before that, when pain became a fifth vital sign, and remember, pain is subjective. My pain tolerance is different than Stephanie's and Laura's and Connie's. We began measuring people's pain and treating pain with a drug that they thought had a very small chance of becoming, for folks to become addicted to it. Fast forward 10 years and we're in an epidemic. Is that the reason? Well, no, who knows? There's lots of reasons. This is a multifaceted issue. But you think of all the years that a doctor spends in medical school, and a very, very small amount of that time is spent on mental health related issues and substance use issues, so an addiction. So that's changing now. Just like when anything comes out, anything new, sometimes it takes a while for us to start seeing what the side effects of things are. And now that we know what we know, and the governor has passed the laws that he's passed, and we're shifting as a society to realizing that prescription drugs aren't the answer for everything. We're kind of going back to the basics, and those doctors are getting the training that they need, and it's ongoing. And Laura's organized multiple trainings on addiction and pain for the physicians, and we do that also internally. And the physicians are reaching out to other physicians and encouraging them to adhere to the stricter guidelines and learning about addiction and what the signs are. So I think that it's going to be a shift that, it's been a long time coming, and I don't know if this is even related, but years and years ago when they started packaging food, they didn't know that it was going to lead to the health issues that it's led to now. So, I think that there's lots of reasons, and now I'll pass it back to Laura.
One of the things that we have that's a tool that we're encouraging our physicians to utilize more is the prescription monitoring program. So we've done a lot of work as a group to promote this. We work with Thomas Pasternak. He is the owner and operator of Walsh's Pharmacy. He's a tremendous asset to this community, and he's done a lot of trainings on it. So quickly, the prescription monitoring program, anytime anybody, no matter who you are, get a controlled substance, opioid, benzodiazepine, it goes into the pharmacist puts it into a database, and it tells you what insurance paid for it, if you paid cash, why you had it, what doctor prescribed it. All of us, if you've ever had anything. We are encouraging, now, it's been since 1992, Massachusetts has had it. So now we're encouraging physicians to use that, because if I was someone that had a substance use disorder and has went around to several different EDs to get scripts, well, it's all in this system. And if I went to see another doctor, that doctor can say, well, yesterday you were in Wareham ED, and or a week ago you were in this ED, and you had a car accident, but you paid cash and insurance. So it really can stop a lot of these drug shoppings that's going on with doctor shopping. So we really have worked really hard to encourage the use and educate people on the prescription monitoring program. A lot of people have said, well, I didn't sign a release to get that put in there. It's federal, it's in there, there's no release, your information is in there, and it's information for physicians to use. And so by law, physicians have to sign up for it. We've worked under the scenes to create policies in agencies around the city to use that, to have independent agencies say, hey, we are going, and we've done this, and which is amazing, we are going to have our physicians use this, whether it's the first time this patient's getting this narcotic, whether they have a high risk, if they're a high risk, and so each different agency has clarified that, but that's some of the work that we've done to combat some of this prescription drug epidemic and work with the physicians. You gotta understand, the physicians are a great ally to us, and they are really stepping up and wanting to do better. They are overwhelmed. They are overwhelmed. They're seeing these patients rapidly and with pain issues, and so the law was just passed because before it was only a physician could go in there and use that, but now a nurse can go in there, someone that they mandate to use that system to help them out. So things are being put into place in the community to combat that issue.
Just to piggyback on what Laura was saying too, the physicians are throwing the bodies in the river, at the head of the river, but when the physicians stop throwing the bodies in, the heroin dealers start throwing them in. So that's the thing, if you really want, the more work we do with physicians, the more business we're giving to heroin dealers, basically. There's someone there to pick it up. It's not like if we deal with the physicians alone, the problem's going to go away, because the drug cartels have a lot more resources, even than the pharmaceutical companies have, to get their product on the street, and they certainly know how to market it. So that's a bigger fish that we have to work with too. So it's kind of like a double-edged sword there. Any other questions? And her name's Ann.
Hi, I was wondering what the panel thinks about safe houses, a place where someone could go to use illegal drugs with a person that would monitor it with Narcan.
So for me, I pride myself in being really open to everything. And when I first heard that idea, I said, I didn't know what opinion, and I don't know if I have a strong one yet, but what I do know is if my child was getting high in Boston, where they have this program, and I knew they were getting high in that building with those people who can potentially save their life and get them into treatment, I would have peace. And that's what it's about. So you got to look at it. Does it seem absolutely insane? Maybe to some people, to a lot of people, but if your child is the one injecting those drugs, if they're not on the side of the road or under a bridge where no one's gonna find them, that's better than what they were doing before. So it's just how you look at it, you know, but at the end of the day, it's a life that's gonna be saved. And those services are there if they want them.
So for me is we have to look at this addiction very different than we did 10, 15 years ago. We have to really go with the flow. You know, we have to be able to provide individuals with a safe place. It is true, if it was your child, would you be okay with that? You know, if it was your nephew, if it was your father or your mother. We have to look at other possibilities that can begin to address the epidemic. And if there is, you know, safe homes, safe places where people can get high, where we can connect them to services, you know, let's look at that option.
Any other questions? Way in the back and around.
Yeah, hi, my name is Mary Lou, and this is to everybody up there. Like, if you have been in treatment, if you have been in a treatment program, and it's on, and insurances have covered it, so it's on your medical records, right? Like you're saying that the pharmacist has who's gone there, and to who, and when, how often. Is that true that all of the medical records are on the computer and that people have access to them? Yeah, I do, because I have been in multiple treatment programs, and my doctors are well aware of it, and I just had shoulder surgery for a replacement. They did a nerve block. They knew that they weren't supposed to give me any oxycodone, right? The nurses kept coming into the room the whole time I was there saying, Mary Lou, when the nerve block wears off, you're going to be in pain. You got to get ahead of it now. You got to get ahead of it now. And they were giving me oxys while I was in the hospital after having a 7-year addiction to it. And when I got home, I came home with 2 strips for OCs. And this is supposed to be on all my medical records, and plus I went in and talked to them. I thank God that I'm not, and I didn't have to use that stuff, but that was pushed on me in the hospital.
All right.
So the prescription monitoring program does not have your medical records. The only thing that the prescription monitoring has is the prescriptions that you've received. We all have it if we've had a controlled substance, so that's in there. To say that you're not the first person that has said, I don't want this medicine, and they're given this medicine. So what we tell people is don't fill it. Don't fill that medication. And again, it goes back.
Why is the doctor giving it?
You know what?
No.
Yes, you know, physicians, again, we go back to, we need to educate. I understand your frustration, it's our frustration, but we don't want to ostracize the physicians because we want them to work with us. We want them to understand it. So we're doing a lot of education with the physicians to say, do you understand how deadly this potential is when you give someone with a history? Again, we're going with physicians that have little to no training on addiction, so don't understand that part of the brain and what the effects that it has. And so what we're doing as a community is really trying to empower us to educate them.
There's doctors at Charlton.
Wait, take the mic.
I won't name them. And I was just in a hospital setting. My father passed away. This doctor is addicted.
Let everyone hear you.
When you're saying doctors need to be trained, there are doctors and nurses or hospital people that are addicted themselves. They know the repercussions. And so there's no excuse for that doctor and anybody that works at, so they know. So she said in that phrase, stay ahead of the pain. No physician, no health person should ever say that to anyone. Because who wants to have pain? Nobody. everybody in this room, if I said, would you rather have pain or would you rather feel good? I don't know anybody that would say, oh, I'll take the pain. Yeah, give me the pain, I want that. We all want to feel good. Doctors know that, health people know that. So when she said, oh, there she is admitting, you know, I was addicted for 7 years. Oh no, here's a prescription anyway. I don't understand that at all. And to say, easy to say, throw it away, you know, that's like telling me to throw away chocolate.
I just want to add my 2 cents on that, and I know I'm my biggest advocate when it comes to my health care. If my doctor asks me to go to an appointment, I have done this and I have questioned him why. What is this appointment for? You haven't done any blood work. I have a regularly scheduled checkup coming. What is this appointment for? And I have refused to go in on a couple occasions because we know that they're going to schedule you for things you really don't need to go. If I'm the patient, I'm in control of my health care more than my doctor is. And if I don't want something, I'm going to say, do not give me this. And if they continue to give me that, I'll find another doctor. And that's the bottom line to that. If I am the one that makes decisions on my health care, not my doctor. So I can take their advice, but I can also refuse any medication they want to give me if I don't believe I should be taking that. So
People don't understand. They are their own advocates.
you are your own advocate. You're the only voice you have with the doctor.
Educated for that.
Let me get my name.
I think that part of it is that we have this philosophy of physician as God. That the physician tells us, and we do it. When you go to buy a car, when I went to buy my car, the car dealer told me that I had to have leather heated seats. I didn't want leather heated seats, and no matter how much he pushed for that, I had the ability to say to him that I wasn't going to buy the car from him unless I didn't get it with leather heated seats. But when the doctor says, you need to take this prescription, something clicks in us and we say, oh, he's smarter than us, he knows more than us, we must follow. We have to change that attitude. We have to say that we make decisions about our bodies. We make decisions about our health. And I understand that we're not all completely and totally knowledgeable, but if you, God forbid, had cancer, you would become an expert on cancer. So if somebody's offering you pain medication, you need to become an expert on pain medication in the same way. We're at fault. Doctors certainly contribute to it, but we don't stand up and say, I don't want this. Can I try Motrin first? Can I try Advil first? Can you give me only 5 pills instead of 30 pills?
When you're an addict,
I understand, but I'm talking about what gets you to that point of addict. Okay? And lots of the people that we're hearing get to that point of addict because they started. I mean, I had knee surgery. I was telling Stephanie before. I had knee surgery, and they gave me 60 oxycodone, and then they gave me Percocet to go in between. So every 8 hours of the oxy, every 4 hours of the Percocet. By the 4th day, I was looking for that oxy at the 6-hour mark. By the 5th day, I was looking for it at the 5-hour mark. And by the 6th day, we threw it away.
that's what the health system has to train people on.
Thank you,
That's
Wendy.
what they should
Connie, you want to respond? And just on a lighter note, the leather heated seats, you can't let go without those.
You know, what I want to say is we don't have the answers for everything. You know, this is such a great opportunity for us to talk about some of this, these issues and some of the things that, you know, are going through our minds. But one thing that I think it's important for us all to realize is that addiction doesn't choose class or professional, okay? So, you know, you could have a physician who is addicted. I mean, I just, you know, saw a story on Dateline about an FBI agent who actually, you know, stole the prescriptions and sold them. So, you know, a lot of times we forget that, you know, addiction hits every single person, and we just have to be more educated. We have to be out there advocating for ourselves and, you know, for, you know, our children or our partners, whatever. But one of the most important things is we need to accept the fact that addiction does affect everybody. And, you know, we as society continue to stigmatize individuals just because, you know, someone is a nurse and suddenly became addicted. She should have known better. You know, we don't know what led into that. So, you know, let's be open-minded about, you know, addiction does hit everybody, and in order for us to become more aware, more supportive, we do need to educate ourselves and be more open-minded.
And just before I forget, if people are watching at home, what is there a number or a contact or a website for Learn to Cope that they can go to? Stephanie?
It's learn, the number 2, cope.org. And that'll give you all of the means everywhere that they are available, the times, and it gives you an explanation of what Learn to Cope exactly is and how it got started.
I wanted to add back to your question and maybe to help you. One of the things that we learned throughout many focus groups and key informant interviews in our community was that people needed to feel empowered when going to a physician. They needed to know what the right thing to say is. So we're working very closely with Dr. Angela Halliburton to create a checklist, one for parents when their child has an injury, to ask the doctor what medication, is this medication habit forming, what are the risks. We're also working on another one for adults to take to the physician as well, just a checklist to get out to the community, what to ask your physician. So we hear your concerns. These are concerns of many people throughout the Commonwealth, and we've taken the lead on that to create these checklists to get out into the communities, to put in parents' hands, to put in members of the community's hands, to then take this and say, here, this is created by a physician, to ask a physician. So we're in the works of doing that, and hopefully by the middle of July, we'll have them out and into the community.
Back to the lady in the back. So I recently had a patient who had shoulder surgery, and I had said to her, what are you going to do? She was in recovery. She was open about her recovery. I said, how are you going to handle this shoulder surgery? There is a lot of pain. And she said, you know, the best thing you can do back to being empowered is having the discussion with your surgeon and your doctor. And what she did alongside him was make a plan. Half of her pain was going to be anxiety or fear of pain, right? So having put that out on the forefront, she was medicated prior to the surgery for the anxiety associated with it, and then they had a clear-cut plan on paper that this is what we're going to do, and if this doesn't work, we're going to try this. So there was a care plan in place way before her surgery ever happened. It followed her throughout the hospital, and from a nursing perspective, we become nurses because we want to care, right? We want to make you feel better. And up until recently, making you feel better is being pain-free, right? That's shifting. In nursing school, pain is the 5th vital sign. This is very important, it's subjective, you must medicate their pain. And now we're learning the hard way that that's not the best thing for our patient. You know, a little bit of pain isn't going to kill anybody. But having that plan ahead of time, and from a nursing perspective, I know many nurses who would be more than happy not to give out opiates. More than happy. One, they're dangerous. They can do have a lot of other medical consequences on a whole other level that we have to monitor you for. But two, they're really starting to understand. They see this every day in their hospital beds, what these opiates have done to people. So if they don't have to give it to them, they're not going to want to. But they need to know from you, like everyone said, you have to take control of your own health care. And you have to say, that is not my plan, I am sticking to this plan, and I encourage everybody who knows somebody in that situation to make the plan ahead of time and have that open, honest discussion with your doctor.
Want to follow up?
I did have that kind of discussion. I did tell them, my husband went in and told me the same thing. My brother called and told me the same thing. And when that nurse came in and kept saying to me, you've got to stay away from the pain, you've got to stay ahead of the pain, you've got to stay away from the head of the pain. You don't know what that does to an addict. Like, if you have those receptors in your brain that already are anxious for this kind of stuff, and you're already getting paranoid about it, it just shouldn't have happened. And I did have the discussion, and I did have a plan. I mean, I thank God that I didn't get addicted again, but I'm just saying that it's still there.
And you can also ask about alternative therapies, like Laura was talking about with Dr. Halliburton at the pain clinic, and they have different things. You've already looked into that? Good. Yeah, good. Ice works. Any other questions?
So, my name is Megan, and I'm a clinician for the Youth and Trauma Program. So we might not necessarily work with parents in recovery all the time, but what we are seeing a lot is grandparents who are raising their grandchildren because of their parents, the adult children being in recovery and not in a place to be able to care for their own children. And Stephanie, you spoke about having challenging conversations, and what we see a lot, and I'm thinking of one family in particular, is that for a variety of reasons, it can be difficult for grandparents to accept and understand that addiction is a disease. And so we try to do education around it being a disease model, and that is hard for them to get. And sometimes what happens is grandparents are framing for their grandchildren that parents are making a choice, and that parents are choosing their addiction over them. And so I guess I'm wondering if you have any suggestions on how to intervene and have those challenging conversations in a non-challenging and sensitive way.
Stephanie, Laura, both of you, either?
The biggest thing really is to have the first conversation that these are sick people. When we're talking about someone with a substance use disorder, we're talking about very, very sick people. And sometimes families can understand that better than saying this is a disease, because they're living that process. They're seeing that, you know, this person essentially is living this life and not getting treatment. And it's really hard to educate someone on the brain. But I would start with educate them and letting them know this is a very sick person, and starting with educating them on what post-acute withdrawal looks like, and why this person is like this, and what the person is going through, that they're not sleeping when they're in early recovery or getting clean, and the depression and what that looks like, and the brain is craving the drug, and it's not that necessarily the person wants to be like that, but really bringing home that these are very, very sick people, not bad people, very, very sick people. And the families that I've worked with, again, like Mike said, I started in a clinical background, and I still do intervention work. And that's the first thing I say to the family, that your child is not bad, your child is very sick. And that kind of sparks something in them that says, oh, wait, you know, no one's ever really said it to me like that. Because we look at families that have a child with cancer, and it's like your child is sick, or a child with diabetes, or a severe mental illness, but you have someone with an addict and they don't consider them sick, but you have a very, very sick child. We don't know if they're going to get better, but we can help you get better and understand this a little bit better to cope. And so that's where I would start.
That's a really challenging question.
It's challenging for me in the office.
Right. I think, like Laura said, the one thing they may understand is that they parented them to be different people, right? This isn't the child I raised. And if they can have solace in knowing that for certain, that they did the best job they did and they gave them all the tools, sometimes if you can get them to remember that and say, you still have the same child in this adult body with this sickness. What you did worked, and you saw, if they can see where it started, if they can link it to this event happened, and then I noticed the change, or whatever it may be, then they can start to kind of look at it from a different perspective. You know, maybe there was some kind of trauma that took place that they couldn't cope with, and then this happened, and then go into the disease of the brain. And a lot of times, because this is a very difficult population, their behaviors, I always say, you know, a diabetic is going to present at the door with neuropathy. You know, a cardiac patient is going to have their own set of problems. Where someone living with a substance use disorder presents with almost an attitude, right? Because they're so fearful of this disease that they're pushing away any help. They're sabotaging everything. And if you can help them to identify the behaviors
attached to the disease, and at the end of it, at the beginning, really, it's still their child. You know, they have to go back to where it started and still say, okay, I saw a progression, and kind of connect the dots that way. Sometimes I find that helps, but again, it's individual for every single family. It's going to work for some, and some are just never going to get it. And that's a reality that we have to accept, you know, unfortunately.
You're also talking about generations too, and older generations don't always understand addiction because they didn't see addiction. They knew they had the drunk down the street, or the neighbor was a drunk or whatever, but that was about the extent of it. They haven't seen anything like this before. And I can certainly understand in my culture, the Portuguese culture, if you're talking an older Portuguese person understanding addiction and being a disease, you got a hard sell right there. And going one step further, to get that person to go to a support group, even harder. But if you can, there is learn to cope if that's the drug of choice we're talking about. But there are support groups that understand they're not by themselves and that there are other people going through the exact same things. And when you sit with other people that are living through this, you start realizing you're not the only one going through this. There's a pattern here. You know, I know growing up, well, I had a brother who was addicted for many years. Like, I couldn't figure out why we didn't have spoons in the house. Like, what happened to the spoons? Little things like that you wouldn't even think of. When you start talking to other people, you say, yeah, me too, that happened to me. Which is the best part of learning to cope. I mean, I think that I'm so big on that program. We're so fortunate to have them here. And also STAR has family support too. STAR has an open access program. You can just walk in there in the morning and be seen. So there's so many resources in the community. If you go to the website at STAR, SSTAR.org, you'll have a list of all the programs, including the Bold Coalition, all the treatment programs. These right here are fantastic resources that we have, and I want to get the resources out there. Laura meets every second Wednesday of the month at 8:30, because I never get there in time, 8:30 at STAR. And that's basically the cluster grants that work with Fall River, Taunton, Dayton, and Norton. And she works on the overdose prevention on those grants, which is a subcontract. One of them is a subcontract with the city. They also do underage drinking prevention. And these are open to the public. If someone's interested, they can call me at City Hall, or they can call any of us and get more information on it. And you're always welcome to be there. So I think that just about, wait, there's one more. I'm sorry. We have to go to a commercial break right now?
I was just wondering, we go into homes, every day, and how do we recognize an overdose? How do we know when somebody's having one or about to have one?
Just so happens we have an expert on that right here.
All of us are.
Yeah,
Okay, so how to recognize an overdose? You're gonna look at their fingertips, their lips, if they're blue, if they stop breathing. That's how and if you call out their names and they're not responding, that's how you would recognize if somebody is actually overdosing. And that's when you would call 911. I'm not sure if you, as you're going to homes, if you have Narcan, but, we want people to call 911 right away so that, that person can get the help. It's very easy to recognize that when somebody's overdosing. As soon as they're not responding and you begin to call their name, you begin to endorse some pain, such as rub on their chest or on their lip, and they're not responding, then you know that person is in trouble and you really need to get medical help in there as soon as possible. So calling 911, they will basically, advise you what to do. I would, advise you that if you have the Narcan, that you would administer, but if you don't, you would do first aid. You would see if that person, begins to breathe until the emergency EMS gets there. But those were some of the signs that is if you go into a home you can recognize.
And as a follow-up to that, if Connie's out, drop-in center downtown on South Main Street, you can walk in and they have educators there that will teach you all the signs of overdose and can actually give you Narcan and train you on how to use it. I've gone there myself and I know many people I've referred there. What's the address, Connie? Any hours?
All right, so it is a drop-in center, so I'm going to give you the phone number and the address because remember the beginning of my presentation, I said we're out there in the community. So we're not the 9 to 5 office. There's days we're there until, 10 o'clock at night, but we also started, like today we'll be there until 7. But it's 310 South Main Street, right in the corner of Columbia Street and South Main. The phone number is 508-235-1012. 508-235-1012. And you can just go in, get all kinds of information about overdoses, how to recognize an overdose, how to respond to an overdose, how to enroll in Narcan, or just get education on the Narcan. You don't have to enroll. You can just get as much as education on the Narcan and where to get it and so forth. The other thing too is there's other services in that facility that you might want to become familiar with that could help you with your clients, such as sexually transmitted disease, HIV. All of that comes when somebody's struggling with a substance abuse. So just give us a call or swing by. We're there just to help out not just the client, but you also be a resource to you where we have all kinds of resources available.
All right, thank you. You have a question?
Yes, I just wanted to ask, is it possible to get too much Narcan?
No. So the question is it possible to give too much Narcan? No. Narcan is not addictive. Narcan has no street values. Narcan saves lives. Once you give Narcan, the only thing it's going to do is going to, revive you if you're having an opiate overdose. Some people need more than 1 dose. Some people need more than 2 doses. Depends what, individuals are under the influence. And just one of the things that is important to remember about Narcan is that overdose doesn't happen instantly. It can, happen up to 3 hours. So it depends when the person overdosed and how much they have, so to administer 1 dose or 2 doses or even more than 3 doses. But this is why it's important that we encourage individuals to call 911.
Just before we close, there's something that anybody who listens, I will tell, there's been a shift in our community as far as what we're seeing on the streets is for drugs. So, and it goes back to the Mexican drug cartel, right? It costs a lot of money to import heroin, to grow the poppy, to produce it. What they're doing is they're replacing that with synthetic fentanyl. So you're going to hear more about that. I know Brockton, if you talk to the chief of police of Brockton, I don't have a heroin problem on my streets, I have a fentanyl problem. We're starting to see that in our city, and twofold. So what Connie's saying sometimes requires more. Often what I'm seeing from an emergency room perspective is multiple doses of Narcan that are still not waking our patients up. And then they come into the hospital and they report that they've used heroin, but they're coming back negative in opiate screens. So for your parents who you say, I feel like they're getting high, they really looked like they were high, but the drug screen said they weren't, what's happening is they're using fentanyl. Not intentionally, it's not what's, a lot of them are very afraid because fentanyl is the drug that, these are the people we find with a needle in their arm dead. It takes them, it's almost instantaneously often. But again, from your perspective, you have parents who I'm sure are DCF involved, they're getting negative drug screens, but you think something's just not right. I'm hearing the same thing from probation. The probation violators are going in and saying, yes, I use being straightforward with their probation officers, and they're testing negative. STAR is now, they have a special test for everyone going in that just screens for fentanyl.
what is fentanyl?
Fentanyl is a synthetic opiate, okay, so that we make it in a drug company, where the Mexican drug cartels are kind of making up their own recipe for fentanyl, and that's why Narcan is not, working as well, because who knows what they're mixing in with that drug. But at one time it was thought that it was mixed in with our drug supply. It is absolutely 100% here. I've had multiple people overdose, and the thing is, they know it looks different. It looks different, it fills the syringe differently, they don't have to cook it like they do heroin, so always ask, I learn because I ask. In order to, it doesn't break down, so you have to do an opiate confirmation, right, to break down what type of opiate is coming back positive. It could be methadone, it could be, there's different ones. For the hospital, our physicians are just starting now because they're thinking, well, maybe it's bath salts, because we know bath salts doesn't come up in our drug screens. No, it's fentanyl, and we're seeing it time and time again. So until we look at it differently, but just know that it is on our streets, this is getting worse. Fentanyl is a whole nother ballgame. And unfortunately, what do you think is going to happen, right? People are on probation, they know, they're starting to learn real quick, they're getting a negative urine screen. Before I may have been afraid of it, but now I'm just going to try to use it safer, because I know I'm going to get away with my probation. It's like a whole, and I'm not saying that's what they're all going to do, because a lot are like, oh my God, I use fentanyl, I don't want to use fentanyl, because they see people dying. So this increase in deaths, when the state broke down the numbers, I think it was something like 63% of all of the overdoses from like January to March were from fentanyl. So now they're looking at it from a state's perspective on how can we do this better, because we have another problem. So I just wanted you guys to pass that knowledge along.
Narcan just works against opioids, so for instance, if some, yeah? Okay, so if they've overdosed on clonopins.
So she just said Narcan just works against opioids. Yes, Narcan just works against opioids. And so I just wanted to say that this is why prevention is so important, because all of these trends keep happening. It's important to get into schools and get above it, and get in front of that, and get in front of deceptive.
And it's important to do this, and keep doing this, and keep doing this, and keep doing this.
All right. Everybody? All the questions? All right. I just want to thank Mike Aguiar for being our moderator. Give him a round of applause. And I want to thank Laura, Connie, Stephanie, and Rachel. Between 11 and 18 to Florida. Any greater Florida. Thank you.